I just want to kindly ask if we can unmute everybody but the speaker. So our next speaker is going to be Dr. Eman Elgindy. She is a consultant in reproductive medicine, a professor actually, from Egypt, director of Egypt IVF Registry Forum, and she is the Secretary General of Egyptian Foundation of Reproductive Medicine and Embryology. She's going to be presenting her topic about endometrioma and ART and updated evidence and best practice about these topics. Thanks a lot. The scene is yours, Secretary.
Thank you, Mr. Chairman. Will you hear me clearly? Okay, the voice is good?
Yeah, that's perfect.
Okay, thank you for everything, and I enjoy the meeting actually. Well, I'm going to address endometrioma and the ART evidence and best practice. Identify the effect of ART on endometriosis, assess whether there is an optimal ovarian stimulation protocol or alternate strategy for these cases, and distinguish the role for surgery for endometriosis before ART, current evidence, and best practice. No conflict of interest. Well, for the first objective, according to MSERM, in endometrioma, we have adverse impact on uterus. There is altered receptivity, resistance to progesterone, defective implantation marker like alpha V beta 3 integrin, selectin, hoxa, etc. For the ovaries, there is decreased response to ovarian stimulation, more HMG needed, less oocyte number, less quality, suggested abnormalities. This meta-analysis and systematic review in human reproduction update based on 5 studies, there is no adverse effect for endometrioma on the outcome of ART based on this meta-analysis and systematic review. However, another systematic review and meta-analysis, and here they divided endometriosis either into stage 1 or 2 and stages 3 and 4, including endometrioma. For implantation, there is no adverse effect for stage 1 and 2 endometriosis on implantation, but based on 8 studies, there is adverse effect for stages 3 and 4 in implantation rate for endometriosis. For clinical pregnancy, stage 1 and 2, no adverse effect. Stages 3 and 4, there is adverse effect for stages 3 and 4 endometriosis on clinical pregnancy rate based on this meta-analysis and systematic review. This is large data from US. They are comparing between endometriosis and the male factor. As you see here, it's more than 100,000 cycle of endometriosis, more than 300 cycle of male factor. Well, for the needed dose of gonadotropin for controlled stimulation, the needed dose in endometriosis is higher than male factor. For cycle cancellation before retrieval, it's more in endometriosis. For the trend of getting oocyte, we are talking about getting 0 to 10 oocyte, 11 to 20, 21 and more. There is always trend for getting less number of oocyte in endometriosis than male factor based on this large data from US. According to US data also, endometriosis had lower implantation, lower clinical pregnancy, and decreased chance of live birth in comparison to male group. This is one perspective. There is another perspective we have to keep in mind based on this large data again from SART from US. The objective here was to assess impact of endometriosis alone or in combination with other infertility diagnosis on IVF outcome. We are talking about more than 7,000 autologous fresh and frozen ART cycle from year 2008 to 2010. Actually, according to this large data, patients with endometriosis only comprise 11% of the study. However, the majority reported a concomitant diagnosis. So when we are dealing with endometriosis, many of these cases we are dealing with not only the sole diagnosis of endometriosis, but it's combined with other pathologies. Here, male factor in 42% of cases, tubal factor or diminished ovarian reserve. Endometriosis, according to the data, when isolated or with concomitant diagnosis, had associated with lower oocyte yield in general, compared to those with unexplained, tubal factor, and all other infertility diagnoses combined. Women with isolated endometriosis had similar live birth rate compared to other diagnoses. However, women with endometriosis with concomitant diagnosis had lower implantation and live birth rate compared to unexplained tubal factor. I think all these are very interesting data. Lastly, I got this study last year, 2021. Like Dr. Thomas actually said, we know this group of patients already have lower ovarian reserve than their comparative control, whether having normal, whether having even other benign pathologies in the ovaries rather than endometriosis. So when they compared, this is retrospective data comparing 862 endometrioma versus 862 non-endometrioma. The group were matched whether for age, for infertility duration, for body mass index. As you see here, AMH basal and antral follicle count were originally lower in endometrioma than non-endometrioma. FSH were higher in endometrioma than non-endometrioma. So we are dealing actually with a relatively compromised group of patients with basal lower ovarian reserve than their comparative control. When they compared the ART performance of endometrioma versus non-endometrioma, number of oocyte retrieved, number of M2, maturation, fertilization, available embryos, top quality embryos, all were significantly lower in endometrioma than non-endometrioma group. The number of top quality embryos also were lower. Live birth rate per cycle was comparable, but, which is very significant, cumulative live birth rate per patient in general is lower in patients with endometrioma than non-endometrioma group. So again, this is the impact of endometrioma on ART outcome. What else? For miscarriage, it's not only just getting pregnant. For miscarriage, based on this large data, miscarriage rate was significantly higher in women with endometrioma compared with control. Second, according to ESHI guideline came this year about endometriosis. According to ESHI guideline and its strong recommendation, clinicians should be aware that there is an increased risk of first trimester miscarriage and ectopic pregnancy in women with endometriosis. What else? Okay. ASRM Committee Opinion 2012, women with endometriosis have higher incidence of preterm preeclampsia, antepartum bleeding, and cesarean section. Please turn off the sound. So, but ESHI 2022, yes, clinicians should be aware that endometriosis associated complications in pregnant are present. They are rare but present. However, these findings are based on low and moderate quality of studies and should be interpreted with caution. Yes, we should put in mind, but we shouldn't exaggerate because they are not that common. What about the effect of ART on endometriosis? First, and very important, the risk of BID. These are large data. We are talking about almost 6,000 transvaginal ultrasound-guided oocyte retrieval. They had 10 cases of acute BID. 8 of the 10 cases were diagnosed of endometriosis. So the recommendation was, we have to put this in mind, a more vigorous antibiotic prophylaxis and better vaginal preparation are recommended when oocyte pickup is performed in patients with endometriosis. I will strongly support this. According to ESHI 2022, in women with endometrioma, clinicians may use antibiotic prophylaxis at time of oocyte retrieval. What else? There is concern that with controlled stimulation on endometriosis, we might exacerbate the symptom like dysmenorrhea, like menorrhagia, or whatever. However, based on this study, ART did not exacerbate symptoms of endometriosis, whether dysmenorrhea, dyspareunia, or pelvic pain, and it did not negatively impact the quality in women with endometriosis. So we have to reassure our patient about this. What about the risk of recurrence? When you are doing the excessive stimulation and the retrieval, etc., could this exacerbate endometrioma after recurrence or after excision or whatever? No, based on this ESHI guideline, women with endometriosis can be reassured regarding the safety of ART since the recurrence rate are not increased compared to those women not undergoing ART. And the same also for deep endometriosis. Clinician can perform ART in women with deep endometriosis as it does not seem to increase endometriosis recurrence per se. So we have to reassure our patient regarding this. What about the optimal stimulation? Is there an optimal controlled stimulation for ART in these women or in any alternate strategy? Well, we know the old Cochrane review, which suggested that long suppression, giving agonist, long protocol, and even longer suppression 3 to 6 months prior to ART increase odds of pregnancy by 4-fold. However, this Cochrane was based on only a limited number of studies. Total number of patients was 165 patients. And actually, in the last years, there have been many studies against this conclusion. So I got short and I got you, ladies and gentlemen, the issue 2022 recommendation regarding this issue. The extended administration of agonist prior to ART in women with endometriosis is not recommended. And this is a strong recommendation, as the benefit is uncertain. And I think this is very important recommendation. There is insufficient evidence to recommend prolonged administration of oral contraceptive or progesterone also before the procedure to increase the pregnancy. There is no issue at all to do this. What about the induction protocol? To give agonist or antagonist, this has been early interesting study for endometriosis stage 1 and 2, for cases with resected endometrioma, and for active endometrioma. Within each of these two groups, they compared agonist and antagonist performance in this group. Endometrioma and inactive endometrioma, the number of M2 oocytes, the number of available embryo were significantly higher upon using the long protocol than the antagonist protocol. However, clinical pregnancy, abortion, and the implantation were quite comparable between agonist and the antagonist. So this have been a retrospective analysis. And so they suggested that even pregnancy is comparable, however, might be with higher number of embryo available, the cumulative life births might be higher. However, this needs to be actually confirmed in a properly sampled randomized controlled trial. What about the follow-up studies? This study by Professor Banagayotis. This is a retrospective cohort study, 386 endometriosis patients undergoing ART, classified according to the revised EFS system. Patients stimulated either with the long or antagonist, and patients were divided into endometriosis stage 1 and 2, endometriosis stages 3 and 4, and within each group divided based on the analog used. Results: patients with endometriosis stage 1 and 2 had a tendency for higher clinical pregnancy and live births in favor of agonist use, which is interesting for endometriosis stage 1 and 2. However, stages 3 and 4, no difference between agonist and antagonist, again in pregnancy outcome. So, issue 2022, the recommendation is specific protocol for ART in women with endometriosis cannot be recommended. Both agonist and antagonist can be offered based on patients' and physical characteristic, physician preference, and no difference, frank statement, no difference in pregnancy in live births has been demonstrated. However, I like to remind you, ladies and gentlemen, that we have a privilege in antagonists, especially in endometriosis cases with high ovarian reserve. There is always, we have to keep in mind the risk of OHSS, and this group of patients are very vulnerable. They have congested pelvis, and actually OHSS would be not that good for them and for us. So there is always the privilege of antagonist. If there is risk of OHSS, we can just give the agonist trigger, freeze all, no HCG, which is a privilege for cases with high response. So again, it's a patient-tailored protocol. What about a possible alternate strategy? This is very interesting study. They compared the fresh and frozen. 415 were due to endometriosis, and in these cases, down-regulated frozen transfer cycle is associated with higher live births and the higher clinical pregnancy. And for these cases, when they compare the fresh cycle versus frozen with down regulation before the frozen. So they give agonist before the HRT. So when they compared the outcome, the pregnancy was higher in the down regulated frozen transfer group. And it was interesting study because we know with controlled stimulation, we are giving a supraphysiologic steroid level, we are exhausting the receptivity. So maybe with the frozen cycle, we are sparing the endometriotic women, which is already maybe have a compromised receptivity we are doing the suppression with the long, and we are doing the preparation, so this might be an option. And actually there have been follow-up studies. This study in 2018, it said the deferred embryo transfer strategy improve cumulative pregnancy rate in endometriosis-related infertility, a retrospective matched control study. This is 135 in the fresh transfer, 135 in the deferred ET group. So they did not do the fresh transfer. Clinical pregnancy rate was significantly increased in deferred embryo transfer compared to the fresh. Also, ongoing pregnancy rate was significantly higher. So the conclusion that our preliminary results suggest that deferred embryo transfer for endometriosis is an attractive option. This is another study. It's a fertility and neonatal outcome of freeze-all versus fresh embryo transfer. This is a retrospective study of patients with advanced endometriosis undergoing first embryo transfer. There have been 506 women in freeze-all group and 255 women, 55 women in fresh group. Result in our matched cohort, the implantation, clinical pregnancy, and live births were significantly higher in freeze-all groups compared with fresh transfer. And this is actually a more beneficial effect of freeze-all cycle was found in patients who got more than 15 oocytes. And actually, I will vote strongly with this. Whenever you are having 15 oocytes or more in endometriosis, it's much better to do freeze-all to spare this lady and spare ourselves any extra headache from OHSS or any sequelae. Well, and also it appears that there is a privilege in pregnancy rate. Well, for the surgery for endometrioma, we know this very famous figure, the risk of surgical treatments, a risk of no touch. Well, with surgery, this is major concern of the ovarian reserve. And in addition, which is very important, the surgeon competence and learning curve to leave the endometrioma, accelerated progression of disease, and challenging oocyte retrieval. However, what about the impact on ART, which is very important? My lecture is the evidence. So we know the two best predictor of ovarian reserve are AMH and antral follicle count. These are two meta-analysis and systematic review. The impact of endometrioma excision on AMH. This review based on 8 studies and this review based on 5 studies. There is an adverse effect and significant decline in AMH in both meta-analysis after endometrioma excision. Second, when we are considering endometrioma excision, we are considering it maybe to improve the outcome. This is very famous meta-analysis and systematic review in the Human Reproduction Update. This is treated endometrioma and this is it's quite no improvement in live birth rate upon removing the endometrioma. Clinical pregnancy rate quite comparable. Miscarriage rate quite comparable, cancellation rate comparable, mean number of oocytes retrieved. The most important is for cases who had removed the endometrioma, there is higher dose needed of gonadotropin to accomplish the control stimulation. And the antral follicle count, again, which is the second most predictor of result, decline after endometrioma. Another meta-analysis and systematic review in Jan 2018, again, there is no advantage of removing the endometrioma other than sacrificing the ovarian reserve. What about SHE guideline current year? Clinicians are not recommended to routinely perform surgery for endometrioma prior to ART to improve live birth, as the current evidence show no benefit and surgery is likely to have negative impact on ovarian reserve, which is a strong recommendation. Surgery for endometrioma is only done for pain or accessibility of follicles, please, not anymore. Also for symptoms and pain preference, as its effectiveness, the removal of deep endometriosis for ART, its effectiveness on reproductive outcome is uncertain due to a lack of randomized study, again, a strong recommendation. In conclusion and take-home message, it appears that endometrioma has an adverse impact on ART outcome with increased risk of first trimester miscarriage and ectopic pregnancy. ART does not appear to worsen endometriosis. The extended administration of Agonist is not recommended as the benefit is uncertain. Specific protocol for ART in women with endometriosis cannot be recommended. It appears that frozen transfer might be of privilege in endometriosis patients, especially for those getting more than 15 oocytes. Surgery before ART does not improve outcome and decreases ovarian reserve. Thank you.
Thanks a lot for your presentation. I think now we are